Hi there, I'm Dr. Laura Robin, and welcome to my presentation, Empowering Your Patients Through Functional Medicine. It's not alternative, it's osteopathic. I want to thank the AOA for inviting me to give this talk. I feel like the time is right and it's really pertinent, so I'm very excited to be here. Disclosures, I'm owner and CEO of both Rosa Transformational Health and the Functional Medicine Project, which is one of the exhibitors in the exhibit hall. I'm the owner of Advanced Nutraceuticals, and I'm an affiliate of Evexia Diagnostics. So after watching this presentation, attendees will be able to understand the basic principles of functional medicine and the key elements to a root cause approach to health, to understand how evidence-based and root cause diagnostics and therapies are used to slow, stop, or reverse progression of common chronic illnesses and conditions, to understand how evidence-based root cause principles can be a part of every physician's practice and why they should, and to understand the relationship between the philosophies of osteopathic medicine and functional medicine and how the root cause approach to health brings us full circle. About me, I'm a graduate of the class of 1988 at PCOM, and I'm second generation DO. My dad, Murray Robin, graduated in 51, and he was also one of the founders of NICOM. My residency was in public health and preventive medicine at Johns Hopkins, and I'm boarded in both public health and preventive medicine, family practice and OMM, and also integrative and holistic medicine. I recently was certified by the Institute for Functional Medicine as a functional medicine practitioner. I've been in private practice quite a bit. I spent 10 years as the director and medical director of the Student Health and Wellness Center at Southern Oregon University, and I'm currently working with the Functional Medicine Project, which was founded this year. So in my career, unlike my dad's, where he was in the same place for 40 years, I wandered the desert for a good portion of time. And I was looking for kind of looking for the truth in medicine. What felt really right to me? What was the truth for me? I'm really excited to present to you what I found, and here we go. Let's see what you think. I started my career, my first job was on the Navajo reservation in Kayenta, Arizona. I woke up there. I'd come from medical school and we learned everything about anatomy and physiology, biochemistry, cell biology, all these really cool things. And I was so excited to be able to use that stuff with my patients and really help them to get better. And what I found, as I'm sure many of you found when you went into practice for yourself, that we knew all kinds of stuff, but the reality was we only had a certain amount of time with our patients. Time was so short and we barely got to know our patients. It was a struggle. We wanted to help them. We wanted to fix them. So I found myself in a sense, disappointed at the fact that I really didn't feel like I had enough time with my patients. I wasn't really able to dig down with them. The other thing was, one of my first days in the emergency room, I had a patient come in who looked like he was having an MI. And I had come from Philadelphia. We had seen a lot of MIs. I called my supervisor. I said, Steve, I think this guy's having a heart attack. And he said, well, nobody has heart attacks around here. People just, this population just doesn't have heart disease. Well, that had been true for the Navajo population. But what I saw in the few years that I spent working with these people is that we were at the very beginnings of a big epidemic of chronic illness, of cardiovascular disease, of diabetes. And it was very clear that it was very much related to major changes in lifestyle that this population had unfortunately had in the 20 to 30 years before that. But I was treating people kind of at the end. I was giving them medications and medications and medications, and I wasn't feeling like I was really able to help them kind of upriver, as we say, help them to prevent many of the things that we were seeing. So I decided to go into public health, and that's kind of what started my journey. And we see it now more than ever. But most clinicians don't have enough time with their patients because of the short time, and also just that we're expected to help people in the moment as much as we can, that we're medicating people a lot, maybe even over medicating people. We're guessing and we're saying, well, try this, and if this doesn't work, maybe we can try that. And we're kind of playing, as we say, whack-a-mole with our patients' symptoms. Let's see how this helps you, and if it doesn't help you, then let's try something else. And we know that we're often not getting to the root of the patient's problems. We know that they keep coming back, they keep getting worse. And for me, this was very, very frustrating. 60% of adults in the United States have at least one chronic health condition, and 42% have 2 or more chronic health conditions. At least 80% of chronic illness we know is directly related to lifestyle. We also know that the average older person takes 5 or more prescription medications every single day, 5 or more. And then we also know that 15% of hospitalizations in elders are related to adverse drug reactions. Chronic diseases account for more than 86% of healthcare costs as well. So that is something to really pay attention to. I'm going to show you a couple of different studies. BMJ clinical evidence looked at 2,500 treatments that had been done. And then they looked at the literature to see if there was substantiation for these treatments from clinical evidence, whether there was actually clinical evidence for the treatments that were the 2,500 treatments that were most common. And what they found was they could not find clinical evidence for 46% of treatments that are considered to be usual in the medical field. They found beneficial clinical evidence or clinical evidence that treatment was beneficial in 13% of the cases, and that it was likely to be beneficial in 23%. But 46% were not substantiated. And additionally, 18% were either trade-off between benefits and harmful, or unlikely to be beneficial, or likely to be actually ineffective or harmful. The New England Journal of Medicine reviewed 146 contraindicated medical practices over a 10-year period of time from 2001 to 2010. And they looked at the literature for these medical practices. And what they found is they found that in 40% of the literature that they looked at, 40% of the literature actually contraindicated a medical practice that was currently in use. 38% of the articles actually affirmed an established practice, but 40% actually reversed established practice. So this is all something to think about, because when we think about practicing medicine, we think we're practicing evidence-based medicine. We think that everything's been proven. And if we really look at it, there's an art to it. There are things that we're doing because they were passed down to us through our medical training or through our residency training. And not everything is clinically proven. So I searched and searched and searched. My time in the desert was that I was in public health for a while. I realized public health is a beautiful way to treat populations, but I felt a need to really look at how to help individual patients as best I could. I actually woke up to get very excited about osteopathy in the cranial field, and started studying more about this. This was about 25 years ago. And I started going to Cranial Academy conferences. And what I found is I found my people. I found people who are like-minded, people who are willing to look outside of the box, MDs and DOs who are really interested in integrative medicine and approaching their patients from a more natural and basic perspective. And that kind of got me into integrative medicine and learning a lot more about nutritional medicine. And eventually I started to see the term functional medicine. And that's what we're going to be talking about today. We're going to be talking about functional medicine, what it's all about, how it can be applied in practice. The words functional medicine, the term was coined by Jeffrey Bland, who's a brilliant naturopath, and it was coined about 1990. He talked about it as a discipline that married progress in basic medical sciences with expertise in clinical medicine to address the growing problems that are associated with chronic disease. And things progressed, and IFM was eventually established, which is the Institute for Functional Medicine. And then they received ACCME accreditation by 2001, and eventually it became a nonprofit educational foundation as well. Functional medicine determines how and why illness occurs, and it restores health by addressing the root causes of disease for each individual. So some of you might recognize this man. But I'm going to talk a little bit about what I got right off of the functional medicine website. And you'll tell me if you feel like it sounds familiar. Functional medicine is not a test or treatment or a supplement. It's a new way of thinking. It focuses on the whole picture. It focuses on patterns and connections. It focuses on finding the causes that lead to the clinical imbalances. And it focuses on learning how to create balance. Does any of this sound a little bit osteopathic to you? Yeah, it did to me too. So I'm going to go on and explain the principles of functional medicine and of root cause medicine. Then we're going to kind of bring it around and see how alike we are with osteopathy. I'm going to spend a little bit of time on this slide. This is called the functional medicine tree. You see a tree, you see the roots, you see the trunk, you see the branches, you see the leaves. You can look at this like as if it's a person, okay? And as a person with their illnesses, their ICD-10 codes, and all of that kind of thing. If you look at the very top, you see all of the specialties, the medical specialties, cardiology, pulmonology, gastroenterology, endocrinology, all these special separate branches of specialties, right? And you can look at maybe the little leaves that don't have anything on them. Those are maybe the ICD-10 diagnoses. These are the diagnoses that are being given, that are being held by cardiology on one arm, on one branch, and pulmonary on another branch, and hepatology on another branch, and immunology on another branch. Okay, but if you look down deeper, before the branches even start, or maybe when the branches are just starting, that's where people start getting signs and symptoms. But if you look below that, and you look from a systems biology perspective, there are systems that are working in the body that become imbalanced. The way the Institute for Functional Medicine has organized this is it gets a little bit confusing or a little bit complicated, but I'm going to go through it quickly, and then I'll try and help you sort it out. But there are 7 core clinical imbalances that can happen in the body. We're looking at from a systems perspective, 7 systems. One is assimilation, which would include things like digestion and absorption and the microbiome and respiration, that kind of thing. Defense and repair. So we're looking at the immune system and inflammation, inflammatory processes and infection, that kind of thing. Energy is the third one, and energy regulation, the health of our mitochondria, which are so important to our cell health and function and to our energy function. The fourth one is biotransformation and elimination, which is toxicity and detoxification and elimination of toxins. The fifth one is communication, the endocrine system, the neurotransmitter system, the immune messengers, and cognition, nervous system, that kind of thing. Transport. The transport system would be cardiovascular, lymphatic system, things that allow for transport around the body. And then the last one is structural integrity. That would be from subcellular membranes to the whole musculoskeletal system. So those are the 7 core clinical systems that can become imbalanced. Below that, we've got antecedents, triggers, and mediators. So what happens, the antecedents, triggers, and mediators are what happens to a body to imbalance it, to cause it to be imbalanced. So an example, antecedents are things like genetic predisposition, or pre-birth or birth trauma, things that happen before birth or around birth. Triggers would be things that happened to a body, things like a car accident, puberty, childbirth, infection, COVID. These are all examples of triggers. And then there are the mediators, that are things that are just going on in the body all along. And mediators then can play into all of this and all of the dysfunction. Mediators would be things like elevated blood sugar, or inflammation, or low status of nutrients, that kind of thing. So we look at, when we're trying to figure out what's going on with a person, we want to look at like what's going on in their systems, but below that, we want to look at even a timeline of antecedents, triggers, and mediators to try and sort through what happened when and why and how and what triggered what, because that actually will help us to unwind a lot of this stuff. Just like in osteopathy, we want to unwind, right? So, and below that, of course, we have genetic predisposition, and we want to pay attention also, just like in osteopathy, to mental, emotional, and spiritual influences, and also to experiences and attitudes and beliefs. And then at the very base, we want to look at the personalizing lifestyle factors and environmental factors like sleep and relaxation, exercise and movement, nutrition, hydration, stress, resilience, relationships, networks, and also environmental factors like trauma or microorganisms, infections, environmental pollutants, that kind of thing. In my practice, wanted to make it kind of easier for patients to understand, but I also find it's easier for practitioners to understand when I'm teaching. When I take a look from a root cause perspective, and I want to dig into these complicated systems, but I want to do it in a very organized manner, I sussed out 12 key elements when I approach from a root cause perspective. First is that I want to modify the effects of genetic or familial predispositions. I want to optimize key nutrients and use food as medicine. I want to recognize gut health as the key to the health of the body. The gut is so important to the health of the body. It is not that the gut is the center of everything or that it is the cause of everything, but if you have chronic conditions and you're trying to reverse them, to improve and optimize your health, we need to pay attention to the gut. The gut has to be a piece of that puzzle because it can be such an influence on so many systems in the body. We want to minimize effects of food allergies and sensitivities and intolerances and their roles in health and illness. We want to reduce toxic load, minimize toxic and exposure, and enhance detoxification pathways. We want to optimize sugar and insulin and lipid metabolism. We want to boost the immune system, and we want to also, very important, minimize inflammation, which is at the root of so much chronic illness and degeneration. We also want to pay attention to those beautiful little mitochondria in each of our cells that are making our energy and that are also responsible for cell health and cell function. We want to optimize the adrenals and the thyroid and the sex hormones and all the hormones. We want them to be in balance. We want to minimize the effects of stress on health, and we also want to optimize sleep. We want to improve lifestyle factors and enhance emotional and spiritual health. And then when all of that's done, what I found in my practice is when all of that's done, 80 to 85% of people get about 80 to 85% of what they need. And then there are still the people who have things going on and who may need a deeper dive and a deeper look. So we then identify and address deeper roots and to chronic illnesses and symptoms. But the first 11 are really the basics. What needs to happen from a root cause approach to really, as I tell my patients, like dig down with a backhoe and get in there and clean things up and rebalance things and bring in the nutrition and bring down the inflammation and clean everything up. And then let's see how things are working. It's such an incredible process. I had a clinical program for from 2015 to 2021. We were kind of spit out by the pandemic, but I worked with almost 600 people, and we partnered with them for a period of time, and usually about 4 to 6 months. After orienting them, we'd get basic labs on them. When I say basic labs, I mean functional medicine labs. The regular CBC, Chem Panel, TSH, I call them the "Are you about to die" tests, because they're totally necessary. And I do them, there's no question, they're totally necessary, but they're going to tell us if there is some, are there big, bad, ugly things going on in the body, big, bad things that are putting people at risk for hospitalization or death. The basic labs are telling us generally if there's a crisis. There is an expanded panel of labs. If they're done on a cash basis, they can be super inexpensive. You can get a gorgeous panel for about $200 or under $200, but a basic functional panel adds really important factors into the labs and can give us a beautiful, much more detailed view of what is going on with our patient. I have found that it's so useful both in educating the patient and also in being able to suss out really what is going on with that patient. Our program also included work with a nutritionist. We had coaches, and this was so important, not only for getting over humps when we're changing diets in the kitchen and that kind of thing, but also for holding accountability, for just really helping to support people and keep them, emotionally in the game. We had classes like how to shop in a grocery store and how to batch cook in the kitchen, those kinds of things. I did follow-up visits pretty regularly to see how folks were doing. And then at the end, usually in about 2 or 3 months, we would do follow-up labs. And it was pretty amazing what we were able to find. So in addressing our little boot camp, so to speak, included these things. It included, we had folks eliminate foods that were commonly that are commonly the cause of food sensitivities and allergies and intolerances. We had them remove additives, preservatives, dyes, these kinds of things, and basically took people down to what we call a paleo autoimmune protocol. We used targeted nutraceuticals to help the gut repair itself, and very often with most people that takes about a month. It's not a really long process. If we're removing all the bad stuff and then we're giving them nutrients to help support their gut, the gut can repair itself that quickly. Sometimes it takes longer, sometimes it takes a deeper dive, but a month for most people was about right. We optimized their nutrient intake through food and also through some supplementations, vitamin D and omegas, the important things that it's really hard to get in a diet alone. We really worked on minimizing toxin exposures and exposures to allergens and sensitivities and reactive foods. And then we worked on enhancing detoxification pathways in the body. And then, of course, optimizing lifestyle. So optimizing sleep and starting some body movement and working with learning how to manage stress and how stress actually comes into the body. And also self-care. Again, we had coaching and accountability as part of the process. I'm going to kind of explain several areas in which functional medicine differs from conventional medicine. I'm going to use Sarah, who's 32 years old, as an example. She's going to give us an opportunity to dive into several different areas in which functional medicine, looking at things from a functional or root cause perspective, is quite a bit different than working from a conventional perspective. And you'll see where it is different and how that can potentially be incredibly useful. And again, we're not doing anything here that is not evidence-based. I've got a slide a little bit down the line that talks about how it takes 15 to 17 years for a discovery to actually become a medical practice. Very often, what we do in our practices can be 15 to 17 years behind what we know. So what functional medicine, root cause medicine do is they are constantly looking at the literature, constantly learning and growing and changing with the literature based on what we know. So Sarah, 32 years old, she's a physical therapist. I'll tell you in a minute why, a little bit later, why she's shushing us, but she recently had to stop working because she was just exhausted. She was exhausted. Her brain didn't work. She had gotten married a couple of years before, and they were trying to get pregnant, couldn't get pregnant. Her periods were regular, but they were super heavy. And she was one of these people like, don't get near me for a week out of every month, the really bad PMS symptoms. And she was feeling depressive. She was feeling hopeless. She had seen multiple doctors to try and figure out what's going on. They'd done the basic, are we about to die tests? And they look at her, she's gorgeous, you know, she's thin, she's gorgeous. What could be wrong with you, right? So that's when she came in to see me. On clinical exam, her hair was a little bit thin, but you know, everything else was good. She looked a little bit tired, but otherwise her exam was pretty normal. When we did her labs, we did a series of thyroid labs in addition to some hormones and other things. But I found her TSH was 5. From a functional medicine perspective, is considered elevated. We think people are in their happiest place between 0.5 and 2. But, you know, in conventional medicine, some people are not treating TSH unless it's over 10. And if you've ever had a TSH between 5 and 10, you might know that many people are having symptoms with this. But we also look at things other than TSH. So we looked at total and free T4, which were low normal. And one of the most important thyroid tests that one can do is a free T3, because thyroid is produced as T4 and it converts into T3. So, and T3 is most active molecule. If there's not a lot of T3 circulating, this person is going to be clinically hypothyroid. We also looked at antibodies, which I always do in patients because Hashimoto's is one of the most common autoimmune issues. It is epidemic in nature, and it is severely underdiagnosed. So anyway, her TPO was 949 and her antithyroglobulin antibody was 89. We also did day 19 estradiol and progesterone, and her progesterone to estradiol ratio was very low, very low. And we'll talk about that in a minute. Also, I checked her cortisol levels. We did a salivary cortisol. She did it at home four times in a 24-hour period. And we also tested her blood for the MTHFR variations, which she did have this 677T. I'm going to tell you a little bit about how functional medicine looks at thyroid. Several things can go wrong with the thyroid. So one of the things, basically the thyroid just doesn't make enough hormone. That can be because of nutrient deficiencies or toxins or destruction of the thyroid gland. Another thing that can happen is that T4 is what's made by the thyroid mostly, and then it needs to convert to T3. And sometimes it just doesn't, it just cannot convert. And there are many reasons for that. It can be nutrient deficiencies, it can be inflammatory, it can be lots of other things. If it's not making T3, then the patient is likely to be clinically hypothyroid. Sometimes the molecule that it converts to is a trans form of T3 or what's called reverse T3, which is not useful to the body. There can also be issues with the hypothalamus, the pituitary, and the whole feedback loop there. There can be dysfunction of the receptors. And as we just talked about, there can also be autoimmune dysfunction of the thyroid. The thyroid's the most sensitive gland in the body. It's sensitive to toxins, to inflammation, to other hormones. It's kind of like the canary in the coal mine. And it's really one of the first things, if not the first thing in the body to react to changes and to threats. And as I said, optimal TSH between 0.5 and 2. And then really paying attention to a free T3. Also knowing that when we're looking at a patient who may have almost normal thyroid or low normal, low in the normal range, if they've got Hashimoto's, if they've got circulating antibodies, that kind of blurs the picture. And in a sense, all bets are out the window, and you can't look at somebody, I would caution somebody to look at somebody who's got low normal, what's considered low normal thyroid values. They've got lots of thyroid symptoms, and they also have thyroid antibodies. Because they're in the low normal range, they can be considered to be of normal thyroid. But most of these patients, you really have to go by symptoms. You have to, it becomes a little bit more of an art when you've got antibodies circulating. Now let's talk about adrenals for a second. Is this HPA axis adrenal stress? Is it a thing? And from a functional medicine perspective, I've been testing the adrenals for 25 years. From a functional medicine perspective, it is very clearly documented, clearly evidence-based, and it is most definitely a thing. So conventionally, what we do is we test a morning cortisol, right? We send them for a blood test. Well, when you send somebody for a blood test first thing in the morning, what do they have to do, right? They have to get up, they have to maybe take a shower, get dressed. They're going to walk out their door and go into their car, drive across town, anticipate getting their blood drawn. Now, cortisol rises to any level of stress. So if you're trying to measure somebody's morning cortisol, my opinion, and from a functional medicine opinion, it's difficult to get a first morning cortisol with a blood test. So what we do is we give the patient a kit and we have them go home. It's just a collection kit. They put a swab in their mouth, do it 4 times in a 24-hour period. It also tests their DHEA and their 17-hydroxyprogesterone. And you can get a really good idea about what's going on with their adrenals. So this is an example of an adrenal stress index test result. If you look at the green bar, that's a normal circadian rhythm for how cortisol is produced during the day. It's usually highest in the morning, and that's really what makes us wake up and get going in the morning. And then it slowly drops down during the day, and it's lowest in the evening before we are ready to go to bed. What happens is, and I see this all the time, is when people are in that place where they're having lots and lots of stress, but they have a fairly healthy adrenal gland, when we do these tests, we actually see that the cortisol levels are well above this green line, because people are putting out lots of cortisol so that they can help themselves keep going. When everything else in the body, anything else in the body is not working, when the body is challenged, that body, let's say the thyroid's not working well, or we're not sleeping well, or not eating well, or we're challenged, we have a lot of stress going on, the bottom line gland that is helping us out is our adrenal gland, and it is making cortisol, and cortisol is what's going to keep us standing no matter what. No matter we're exhausted and we have to get our kids to school on time, we are exhausted and we have to get to work, and we have to deal with the stressors, and we have to have that argument, or we have to whatever. The adrenals are what keep us upright. Okay, when this goes on for a long period of time, the system, the axis, the adrenals, the system starts to get tired. It starts to get fatigued, and we see that it starts to burn out. As you can see, this person's cortisol levels are well below the bar, well below the within normal limits range. And this is somebody who is diagnosed with adrenal fatigue. I'm going to talk a little bit about normal steroid pathways. So this is a very complicated slide, right? And this is basically, we're looking at how cholesterol turns into pregnenolone, progesterone, cortisol, aldosterone, testosterone, estradiol. Okay, this is the normal pathway of what happens. And as you see, in order to make cortisol, we make pregnenolone out of cholesterol, then that turns into progesterone, and then that turns into cortisol. Okay, to make estradiol, or first we turn pregnenolone into testosterone, into dihydroepiandrosterone, testosterone, and then it turns into estradiol. Okay. When we are stressed out and we need more cortisol, and our cortisol it can't be made by our adrenals anymore because our adrenals are tired, what happens is that we get what's called a cortisol steal. And this is a very common thing. It's super important to know. And cortisol steal is when, if the body needs more cortisol, it's going to make more cortisol, but it's going to make more cortisol in the favor of not making more testosterone or more estradiol. So then what we end up with is because we need the cortisol. The cortisol is more important than the sex hormones in the body's opinion. And so we get more cortisol because progesterone is being shunted to cortisol. We're getting less progesterone. Progesterone is very, very important to modulate the effects of estrogen. When we don't have enough progesterone to modulate the effects of estrogen, we get an estrogen dominant situation. And so when I looked at the progesterone to estradiol ratio, that showed us that she was in an estrogen dominant situation, and probably because of her cortisol steal. Okay, I want to just touch really quickly because I'm just trying to show you all of functional medicine, or so much of functional medicine or root cause medicine in just this one patient. She has Hashimoto's, right, which is a very common autoimmune disorder. What causes autoimmune disorders? Well, we know that there's a genetic predisposition. Okay, so people, there is a genetic component, but it's really a triad of things that actually makes autoimmune issues happen. So we've got the genetic predisposition, and very often there's a leaky or inflamed gut, causing inflammation, causing the immune system to get a little bit angry in the first place. And then there's often a trigger, and that trigger could be anything. It could be COVID. It could be any kind of infection. It can be a car accident. It can be childbirth, anything, something that can be a stress event, something that triggers the body into a stress response. And when you've got the inflammation, the pissed off immune system, and then you're adding the genetic predisposition, then the body starts making antibodies, and it'll make antibodies to whatever it's predisposed to make antibodies to, that will then lead to autoimmune disorder. So Sarah's course of treatment here, we partnered with her for 6 months. She did a food elimination protocol, like I was talking about, to paleo autoimmune. She did a gut repair protocol, followed by a gentle enhanced detoxification protocol. We replaced her thyroid with a T3, T4 combo, and that can either be done by using a glandular or by using synthetics. And we enhanced her low levels of vitamin D, gave her methylated folate and cobalamin for her MTHFR variation, and gave her adaptogenic herbs. For those of you who don't know about low dose naltrexone, which is low dose Narcan, it is an incredible thing. It helps the body, given a very, very low dose nightly. It can help the body's immune system to regulate itself. And we use it a lot in autoimmune and autoinflammatory issues. If you don't know about it, learn about it. It's an incredible thing with very low side effect profile. I gave her micronized progesterone to help to balance the problems with the progesterone estrogen ratio until her adrenals could heal themselves. And then stress management techniques and lots of rest and exercises tolerated. So 6 months, her energy improved, her brain fog disappeared. That happened actually rather quickly. Her mood improved, her motivation was better. And at her 6-month visit, she was back to work. She continued to stay off dairy, gluten, and soy, which I would recommend for anybody with an autoimmune issue, but especially thyroid. There's some overlapping of molecules with dairy, gluten, soy, and the thyroid molecules. So, but really in any autoimmune issue, these are the biggest players that can cause gut inflammation and leaky gut and that kind of thing. We continue to supportive nutraceuticals, and at 6 months, she also came in and announced that she was pregnant. So I sent her to work with an endocrinologist who could support her thyroid and her progesterone needs during her pregnancy, and we were happily ever after. Now this shushing that she's doing is really because I'll just make you wait for why she was shushing, and I'll tell you about Jeff really quickly. Jeff was 50 years old. His chief complaint was, I lost my mojo. He just didn't feel strong anymore. He had gained some weight. He was starting to get a little bit high in cholesterol and blah, blah, a little belly and loss of libido and some loss of energy. And I just wanted to use Jeff as an illustration for to explain testosterone levels in men. The insurance companies tell us that the normal levels for testosterone are between 200 and 800. And so if somebody falls between that, they are considered normal. If they fall out of the range, they are considered not normal. So, and if they are too low, then we can give them replacement, that kind of thing. What I found and what is, kind of taught from a functional medicine perspective is that there's normal and then there's optimal. Just because we're in this range, and this is the same with thyroid, it's the same with estrogen, progesterone, testosterone, is the same with all these hormones, is that just because you're within normal limits does not mean that it is optimal for you. When we did Jeff's testosterone level, his level was 350. So the insurance company says that it is within normal limits and they're not going to pay for any treatment. But the reality is that everybody has their happy place. And so Jeff's happy place, is it at 350? Is it somewhere different? And Jeff's happy place happened to be at 750. So we gave him a little bit of testosterone. And there are other things that you can do, like looking at sex hormone binding globulin and using herbs and other nutrients to help to the body to make more testosterone. But the reality is that everybody has a different happy place, and that just because a hormone is within normal limits doesn't necessarily mean that it is normal for that particular individual. I just wanted to mention Debbie was 76 years old. This is another thing that happens in functional medicine. I talked about inflammation as being key to lots of things. It's key to cardiovascular health, pain levels, and oh gosh, it's implicated. Inflammation is implicated in so many things. But she was scheduled to need a knee replacement, and she wanted to optimize her health before she went in for her surgery. So she joined our program and she went through, the same little boot camp that I was talking about. And about a month into it, it was a Friday, and she was supposed to see her surgeon for pre-op on Monday. And she called me in a panic and she said, "Dr. Laura, I don't know what to do." She said, "I'm supposed to go see the surgeon on Monday to get ready for my knee surgery next week. And I was just in the garden all day yesterday. I was in the garden, I was moving around. So I have no knee pain at all." And she's like, "I don't know if I should still get the knee replacement." So, again, I'm glad she asked. And she talked to her surgeon, and her surgeon said, "Well, if you're not having any pain, it's not necessary." But the reality is that knee pain is, we see a lot of people who have arthritis on MRI or on X-ray who don't have any knee pain. And so pain is actually a combination of the anatomy and levels of inflammation. So for Debbie, she brought her levels of inflammation down to a point where she didn't have any knee pain anymore. And she's 2 years out now, and she has not needed that knee replacement. She hasn't been back to the surgeon at all. So I'm going to flip through this really quickly because we are running low on time. We're talking about evidence-based inflammation from blood sugar, from a blood glucose perspective, from a functional medicine perspective. We want to test the glucose and the hemoglobin A1C and the fasting insulin well before somebody's diagnosed with diabetes, because we want to know if they're pre-diabetic or if they're pre-diabetic. If they have insulin resistance, they can do something about it. They can turn it around. I've seen hundreds of people turn around their pre-diabetes and their diabetes just by changing their diet and their lifestyle factors. So important to get there before they have this blood glucose of 126 or whatever it is that conventional medicine tells us to wait for before we test for fasting insulin or hemoglobin A1C. There's so much that can be done, because by the time somebody gets to 126, a small percentage of them are already having protein in their urine. So we want to get people before they start getting the sequela, and they're going to start getting the sequela of elevated blood sugar well before their fasting glucose is 126. or their A1C is 6.4. Evidence-based gut, boy, we could talk about this forever. Again, the gut is central and to the health of the body. I'm not going to have time to go through all of this, so I apologize. But what we're going to talk about is, again, functional medicine lessens the 15 to 17-year gap between scientific discovery and its implementation. It empowers patients to be proactive about their health. It supports co-creation of health between the practitioner and the patient. And it's also an antidote to the healthcare spending and the chronic dependence on the healthcare system. So my observations from having this 4 to 6 month little boot camp program that I had, it was wonderful. I have never had so much fun. It really felt like a family. It felt like I was working with a family. The patients all felt like family coming in for all the different appointments that we had. And it was a very positive atmosphere. There was always celebration. We had bells ringing and all kinds of things to celebrate people's wins, when they would lose weight and when they would be feeling better, they'd get their brain function back and these kinds of things. It was just so incredible to see. But actually, from a measurable perspective, they were reversing their prediabetes and their diabetes. They were healthfully reversing their obesity, their cardiovascular risk factors. We have had MS and lupus and Hashimoto's all go into remission. It's just, it's not uncommon to see this, but when things turn around and are cleaned up from the inside out and the bottom up, the immune system starts behaving itself better. And I ran into somebody a couple of weeks ago who was still in remission 5 years after she had come into us after being diagnosed with MS, and she was on meds and anyway, off meds in complete remission. Autoinflammatory disorders like MCAS, like mast cell activation syndrome, and other autoinflammatory disorders, taking this root cause approach works so beautifully. So how many of your patients have brain fog? How many of your patients complain of fatigue and sleep and mood issues and gut issues? I mean, skin issues. It's amazing how often irritable bowel just turns around when we go through this process and we really clean up from the inside out. So why she had her, Sarah had her finger in front of her, it was the shush sign, which takes me to the hand story, because I have had so many patients who go back to their doctors, they go back to their specialists, to their immunologist, to their gastroenterologist. You know, my ulcerative colitis is gone, my MS is gone, whatever, and they get the hand. They get the hand because the doctor is saying, you know, I don't want to know what you're doing, just keep doing what you're doing. Congratulations, and keep doing what you're doing. And I laugh at this because when I was in private practice and I was doing family practice, I was totally overwhelmed, and people would come in and they'd say, "Oh, I started this new whatever or started this new supplement, and my whatever is gone." And I'd be like, "Great, just keep doing that. That's awesome, 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 awesome." But so the hand is in a sense complementary. It's a compliment to us because we help this patient to bring themselves back to health. It's also rather sad. It's sad because I think it would be awesome if those same doctors, if those same specialists, the endocrinologists and the rheumatologists and the gastroenterologists and the dermatologists would say, what is it that you did? I want to hear about this. And some of them do. But what I'm hoping is that we're in the beginning of a real paradigm change, a really kind of the 100th monkey, where we're recognizing that this root cause approach really needs to happen. And I'm hoping that more and more people, more and more docs, rather than giving their patients the hand, are going to say, what were you doing? I want to learn about this. I want to use this with my patients. So I just wanted to, I found this fascinating. But when I was putting together, this talk, I really realized that the tenets of osteopathic medicine are so similar to the tenets of functional medicine. The body's a unit. This is osteopathic medicine. The person is a unit of body, mind, and spirit. The body is capable of self-regulation, self-healing, and health maintenance. Structure and function are reciprocally interrelated. And rational treatment is based upon an understanding of the basic principles of body unity, self-regulation, and the interrelationship of structure and function. That's osteopathy. Okay, the philosophy is based on listening and partnering with patients. Okay, the latest science and technology, but also to consider options to complement pharmaceuticals and surgery. Okay, so this is osteopathy. So this was my path. This was my circle, my, my coming around and coming full circle. So I started in osteopathic medicine, and as we go around clockwise through the Indian Health Service and public health, and then I found osteopathy in the cranial field and reawoke to that, and then found my people, went into integrative medicine, then learned a bunch about nutritional medicine, and then found that functional medicine was really the root cause approach that really gets to the bottom of things. So I feel like I've come, and just looking at the relationship between functional medicine and osteopathic medicine, I feel like I've come full circle, and I'm so excited to be bringing these concepts of functional medicine and root cause medicine to osteopaths at the OMED22, because it just makes so much sense, and it's really, I think, where we're going as a profession, and where we're going as doctors in general, and where our patients want us to be going. We can help so many more people this way. So just putting the comparison out there, both functional medicine and osteopathic medicine look at the whole patient. Structure and function are interrelated. It gets to the root of the issue. The body has an innate ability to heal itself, and it treats the patient as a whole. I mean, how much closer can that get? How cool is that? So functional or root cause medicine, basically, in summary, it's what we learned in medical school. It's basic osteopathic principles and practices. It's basic osteopathic principles and practice. It helps people to help themselves and to take more responsibility for their health. And it makes for happier practitioners and their teams, and happier and more engaged patients. So take a look at it. Take a look at some of these root cause approaches, because you really are going to be your patient's hero if you do that. You are going to be their hero if you're not already. Hopefully you are already, but you're going to be even more of their hero. So if you want to learn more about it, the first place to go would be the Institute for Functional Medicine, www.ifm.org. And that is kind of, that is really the gold standard, the source. There is a course called AFMCP, which is called AFMCP is functional medicine, putting functional medicine into clinical practice. And it's a wonderful 4 or 5 day course that really gets you started, kind of like a fire hose, but it gets you started. And then there are lots of advanced practice modules that will help you with all of the other systems, like cardiovascular and hormonal and immune, all kinds of things. So it's a wonderful place to learn. Kresser Institute is another really nice opportunity to learn some functional medicine. If people like books, Dr. Mark Hyman he's kind of a big spokesman for functional medicine. He's written probably about 20 books. Any one of his books is going to give you a good understanding of what's going on. Dr. Terry Walls healed herself from severe MS. She was in a wheelchair, and she turned it completely around. She travels all over the world now, helping other doctors and patients to help themselves. She's got some good books out there. Dr. Isabella Wentz is a pharmacist who treated herself through Hashimoto's thyroiditis and is a thyroid expert, has written a number of really good books that are good for you, good for your patients. And as you'll notice when you start reading functional medicine books, that many of them just start to sound alike after a while. Because they're all saying the same thing, because they're all saying the truth. They're all saying what we know about the health of the cells, the health of the body, nutrition, what is evidence-based, and what the studies show. and what helps people to rebalance and rebuild their health from the inside out. So I want to thank you so much for joining me today. It's been wonderful. If you are at the conference, I'm at booth 205. I would love to chat with you, or you can always email me at drlaura@functionalmedicineproject.org. Thank you so much, and have a great rest of your conference.